Hello, everybody. How was your break? Oh, all right. First, before we start the session, I have a small announcement. A mobile phone was found in the ladies' toilet, and it's with Izuchi raised her hand. So we already found the person who lost it. Okay. Welcome to the second session of this conference, of the workshop. It is a very important topic, to be honest. We are talking about taking the health where the young people are and how innovations in the digital space can help us to reach young people. And all of us know that digitalization is taking place around the world, and young people are the ones who are most rapidly adapting to these digital spaces. And digital spaces are even more important when we talk about issues that might be taboo or that might be a stigma. We have a conference about HIV. We have a conference about sexual and reproductive health and rights. And for many of the questions, young people cannot always engage in conversations at school or at home because of these reasons of stigma, and they end up going online. This is very good, but as you all know, online there might be misinformation, there might be all sorts of people providing services, some with commercial interests, some with not the quality of the services in mind. So today what we're going to discuss is how to do this, how to apply this innovation, how to create high quality, stigma-free services, and how to make sure that we reach the young people where they are. We have 5 distinguished people, guests that will be speaking today. And I want to ask my colleague Brian, who's co-chairing, if he can introduce our invited speaker, and then I will go on with the rest.
Sure, thanks, Lyle. So our first speaker is Julian Adong. She's a pediatrician and research fellow at Mbarara University of Science and Technology in Uganda. She has over 12 years of clinical experience working with adolescents and young adults with HIV at one of Uganda's largest public teaching hospitals. Her research work is focused on developing scalable, acceptable, and novel mHealth interventions to improve HIV treatment outcomes among adolescents and young adults in low-resource settings. She's received numerous funding awards, including from Fogarty International, from the Harvard CFAR, and from Thrasher Foundations. And all of these have been focused on developing mHealth interventions to improve adherence and mental health of adolescents living with HIV.
So the next ones are not going to be as comprehensive as Brian's, but we also have Cristianne Wendle. She works with Chomi. It's a WhatsApp chatbot to address gender-based violence. We have Mandisa Zwane-Machakata. She will address community-led monitoring. And we know how important it is that when we develop services for young people to also integrate their vision and how they are perceiving these functions to further be able to improve them. We have Brian Zanoni. He will talk about how to improve the transition between adolescence care to adult care and how e-health can play a role in that. And the last speaker will be Hildah Essendi. She will talk about TICO, and which is really an application with huge reach in Kenya, and that provides good information on SRHR and also access to services. And then I would first like to invite our invited speaker, Julian Adong. Thank you.
Okay, today we are going to try and unpack digital health or mHealth, which I think are cousins of each other, and we'll try and unpack this and look at them as conduits to delivering health to where young people are. And I have no conflict of interest to declare. This is the outline that I will follow. So I will just move on to the next slide. Okay, sorry. There. So I'd like to start by defining what mHealth or what digital health is. For the purposes of this presentation, I will mostly refer to mHealth, but like I said, I look at them as cousins of each other, okay? And there are numerous definitions of what mHealth is. However, I like this one that is beautifully crafted by WHO. And it defines mHealth, and this is what I would like for you to look at mHealth as you think of it in an African setting, as you think of it applied to young people. So WHO defines it as the use of mobile technology to provide healthcare support to patients or technical support to healthcare providers in a direct and underlying low cost and interactive manner. So that is how I look at it when I look at reaching young people in the context of Africa. In the last decade, mHealth has gained a lot of traction in Africa, and some of the reasons are very unique to Africa. What we see a lot of infrastructure barriers to access to healthcare. We see especially geographical, poor road networks, we see physical barriers, and in the recent past, lockdowns, and as well as shortage of health personnel. So mHealth provides a means of leapfrogging some of these barriers in order to provide equitable health care. And also in the recent past, we've seen a change in tides where phone penetration is higher than penetration of sanitation and even water access. So about 48% of people in sub-Saharan Africa have access to phones. And this is a great resource if you think about reaching everyone and not leaving behind anyone who is held back by these infrastructure barriers. So this change in tides has made it possible for mHealth interventions to thrive and make it within the African youth. And then, of course, there's been increased research. So science is driven by research, medicine is driven by research, and we only do things that have been proven to work. So there's been an increased research, especially in the areas of efficacy and acceptability. So the big question is, does it actually work? Do we think this works? So I will try and unpack the literature in a few slides to demonstrate if mHealth actually does work. It might be something we are discussing, but does it work? And I'm sure the presenters after me will give their work and they'll talk about whether mHealth works in this population or not. So I'll start by going to Southern Africa and looking at a qualitative study that looked at the acceptability of a tablet-based application to support early HIV testing. And in this qualitative study, what they found in men 15 years and up, there was high acceptability of this tablet-based intervention. And then I will move up to West Africa and look at a social media-based intervention called the Smart Connections that enrolled 349 adolescents and young adults aged 15 to 24 with HIV and in care. And this intervention was delivered via small Facebook groups. It was a modular intervention delivered by a facilitator, and the endpoint or the outcome was looking at retention in care and ART adherence. What they found at the end of follow-up was that there was actually no difference between the two groups. However, what they found was that there was increased knowledge of HIV in the group that received the intervention. Then I'd like us to move to East Africa and look at a study by Jessica Mbarara et al. That was an RCT that was SMS-based, one-way SMS. And the outcome of this study, the endpoint was to test PrEP adherence among young women aged 15 to 24 in Kenya, in Kisumu and Thika. And what they found, that there was actually no difference between the two groups. Then we move on, still within Kenya in East Africa. And this was a two-way RCT, SMS-based, that looked at women who were pregnant and those who were postpartum, still young women, and who were taking PrEP. And the outcome in this study was to look at one, retention, PrEP retention, and then two, PrEP adherence. And this study actually did demonstrate that there was indeed improved retention in PrEP and adherence in the group that received the intervention. Then I would like us to look at now more data. And here we are looking at a systematic analysis of interventions in low and middle income countries. So in this particular analysis, 27 studies were included. And what they concluded from this analysis was that there was high acceptability, there was high feasibility. However, results were conflicting. And this was mostly due to designs. And some of the issues with designs included being underpowered, included being uncontrolled, and the fact that there were no principles of implementation science that were applied to these studies. So back to our question, does mHealth actually work? What we can say with confidence is that we have high acceptability of mHealth interventions among youth in Africa. However, results are mixed. What we can say is that when mHealth interventions are well designed, they have the ability to decrease disparities in the HIV continuum of care by young people in Africa. And what we clearly see is that there is need for larger and well-designed mHealth interventions that target specifically young people in Africa. I will use 2 case studies of studies that I have conducted in Uganda that will try to understand some of the pitfalls and how you can successfully implement mHealth interventions within Africa, in especially low-resource settings. And I'll start by looking at a study called the PRADA, the pandemic. So this was a study where we tried to describe disruptions in care that happened during the lockdown among adolescents in our HIV clinic. And then we explored qualitatively if mHealth interventions had the potential to bridge disruptions in care. So the study methods were that we enrolled 13 to 24 participants, 86 in total, at that small clinic that you see. And we used a mixed method design where we followed up participants at 0, 3, and 6 months and conducted 35 qualitative interviews. The outcomes were we looked at the proportion of services that were disrupted. We looked at ART adherence, and for this presentation, we looked at acceptability of mHealth interventions to improve these disruptions in care, or to bridge the disruptions in care. This analysis is still in progress, but I'll present some preliminary data. So we see 51% were male, and mean age was 18. Importantly, I would like you to see that we have phone access of 60%, okay? In this population aged 13 to 24, we had phone access of 60%, so very good phone access. And then we had internet access among those who had phones of 70%. So this is a resource that we can actually use to deliver health care. Those who missed a scheduled visit were about 27%. In the qualitative arm, what we found was that there was a high acceptability of mHealth interventions, and participants thought that these were very important, especially in bridging the gap in care that occurred during the lockdowns. And I'll quote some of the quotes from two of the participants. So one says, "But if she, the counselor, is calling you, she could constantly give you advice and give you reminders on ART adherence." And then another one says, "I think costs were cut as I received the treatment while I was at home." Then I look at another one called the USmart, which was an adaptation of the smart connections that I had described earlier on that was conducted in Nigeria. So in USmart, we tried to adapt the smart connections intervention to develop USmart and test its acceptability. So we developed a 12-module intervention that we used on WhatsApp. And we've so far enrolled 20 adolescents and young adults with detectable viremia, and we are following them up to see if their adherence will improve. And we shall measure adherence by looking at levels of tenofovir in their blood levels. And subsequently, we also enrolled 20 adolescents and young adults and their caregivers to see if this intervention actually applies to caregivers as well. Those were some of the targets of the USmart intervention. So what were some of the pitfalls that we've experienced in these 2 studies and that other studies have also experienced? One is during some of the qualitative interviews, we found that parents and even caregivers, and even healthcare workers have a negative perception of adolescents and young people using phones or having access to internet. So we need to find a way of dealing with that. Then there are sustainability issues. We had a lot of times when adolescents couldn't be reached because they couldn't afford the data, okay? But also scale-up issues, so at a higher level than just your health facility. Is the government able to support this? Is your hospital able to support this? Infrastructure issues like reliable internet, and then the hardware that is sometimes required. Then usability, thinking about the font size, the language you're going to use, the cost, high internet costs, having to charge your phone every now and then. Still, there's lack of theory-driven and tailored interventions for adolescents and young adults. And then sometimes there's lack of policy and institutional frameworks to guide even these studies. And then sometimes when I design an intervention, she designs an intervention, these two cannot communicate with each other. So we need to think about how interventions should be designed in order for them to communicate with each other, okay? And then the big elephant, ethical issues. So protection of personal data. An adolescent needs to be comfortable and know that their data they're giving you is actually protected. Some of the considerations that we considered while implementing these studies was using available infrastructure. We thought WhatsApp was ubiquitous, and we thought it used less data compared to other social media platforms. Our interventions were grounded in theory. And then we involved adolescents and young adults and other stakeholders, including the counselors themselves at the inception of the study. And then we ensured that there was data protection that was guaranteed. So we taught the adolescents from the beginning how to safeguard their phones against third-party access while using WhatsApp. Then I would like to touch upon artificial intelligence and mHealth. This is something that has become more and more popular. So we'd like to acknowledge that it's becoming, widely used, and we should also think about, moving in that direction as well. So AI is basically simulation of human thinking processes by machines, especially computer systems. And increasingly, we are seeing AI being used for disease protection, management, using data that is mHealth generated. And it has become popular in Africa. So I looked up the literature and looked up what was available. And what I found was that there are very few AI-powered mHealth interventions, and most are mainstream, things like ChatGPT. However, some are locally directed, like the Afya PAP, which is popular in Kenya and in Uganda. Some of the advantages of AI include it can be detail-oriented and is very good at diagnosing, especially it has been piloted in breast cancer diagnosis and other cancers. It saves a lot of time and can go through a lot of data that is collected in a very short time as opposed to a human being. It could be an avenue in which, a health worker may pay attention to something else, as the chat box, for instance, delivers information to the adolescent. So it allows health workers to focus on something else. And then it's always, so it doesn't get tired, it doesn't sleep like human beings, and the results are consistent. But it goes without us saying that there's a downside, and sometimes usability issues may come up in that you require a level of literacy. It's very costly, and the algorithm might not be personalized. And then it has room for large-scale bias, so a bias may be amplified when you're using AI. And then lack of generalizability. So the fact that a study or data was collected in a high-income country, that data may not be applicable, or the algorithms may not be applicable to us. Then there's also confidentiality and health data security issues to consider. In conclusion, I want you to know that mHealth is not a panacea, it's not a fix for everything. And then before you develop an mHealth intervention, ask yourself if this is what you really need to be doing, okay? And is it something that will work for adolescents and young adults in your setup? And remember, it's always good to look into your box of interventions and pick what has already been done. Don't try to do something very new. And then to conclude, always make sure as you're combining mHealth interventions, combine them with existing interventions like community outreaches, disintegration the differentiated model that is currently available. So combine interventions, don't just try and use one in isolation. And this will promote synergy and increase acceptability. I'd like to acknowledge conference organizers, my mentors, and my funders, as well as participants. Thank you.
Now we give the floor to Cristianne.
All right, thank you so much. Good afternoon, delegates. My name is Cristianne Wendle, and I am here today from Shout It Now to talk to you about Chomi. Chomi is a multilingual gender-based violence chatbot that was developed for South African users to raise awareness about GBV, as well as to connect survivors to support services. Now, I do want to state that while it says South African users, much of the information contained in Chomi is universal and it transforms any geographic boundaries. But if you're looking at information such as how to get a protection order, that process speaks to the South African process. But most of you should have found a card on your chair. You can see that you can access Chomi via WhatsApp and you can engage on it regardless of what country you're from. Also important to note, we did not create nor does Chomi exist in a silo. As Julian just mentioned, it is embedded within a systematic program that addresses HIV, gender-based violence, and sexual reproductive health for young people. So why did we create Chomi? I'm not going to run through all of the stats on this slide, and many of them may be familiar to many of you. Bottom line, the need is great, and particularly the need for adolescents and young women. But we cannot look at HIV without looking at gender-based violence and vice versa. So what is Chomi? It's WhatsApp-based, it's multilingual, and it is a chatbot. Chomi means friend. This was chosen because it is widely understood and it's a fairly inconspicuous name in the South African context. These are the 4 languages that Chomi is accessible in. And the Chomi was designed to allow an individual to explore this information on their own terms, on their own time, giving them information, access, and options, which is a key to being able to be empowered. We know that many survivors never come forward for the health and physical and social support services they need because of barriers. Fear of the perpetrator, blame, shame, guilt, access. These are all barriers. And so it's important that we look for options. How do we bring down those barriers and how do we increase and empower survivors? So Chomi is designed both in content and form based on real application, direct feedback from the field. Our social work teams engaging with clients and giving feedback on what are the needs and challenges that survivors who have come for services face. There are 9 content streams in Chomi. You can see them on the right hand here. And it covers everything from counseling and support, legal assistance, safety planning, which is a big one that a lot of people didn't even know what that means. But that can be for a survivor who's not ready to reach out for services, but there's still empowerment in knowing there's something I can do to be safer in my situation. There's over 640 unique messages in each of the 4 language streams across those 9 in each language across those 9 streams. Important also in the design is that we infuse GBV best practice with information, options, and practical strategies, but infusing that with empathy and affirmation, because we need survivors to understand they are not to blame and they are not alone. So our results to date in terms of our usage. We launched Chomi in August of 2022, and almost 1,600 unique individuals have accessed Chomi. 39% of those users have requested to connect to support services, a number that we're extremely proud of. And each of the content streams you can see in the graph here have been accessed approximately, a user is accessing approximately 2 streams when they go on. So just shy of 3,500 times streams have been accessed, with the most common being connecting to support services, followed by counseling support, and then followed by emergency assistance and GBV info and FAQs. I think also important to note that follows after at 8% is safety planning. Again, something we're really happy to see that stream is being uptaken and people are using that information. We also track language. Now it's important on both, whether it's a content stream or language, Chomi is anonymous. So whether you go on Chomi or you go on Chomi, I cannot track what you do, nor should I ethically. It's meant to be anonymous. So I cannot tell you if you go on what you did, but I can tell you collectively how our users accessing Chomi. So both in the previous line and this speaks to collective, not broken down by individual user. So here we see that English is the most commonly accessed stream at 65%. For those who aren't familiar, South Africa is a country with now 12 official languages. So language is really important. But while we see English being the highest, English is the language that was available the longest. We brought on the languages in different phases, and so therefore we did see the higher uptake of English, given it was available longer. isiZulu came on approximately 3 months later. Important to note, though, within 24 hours of isiZulu being live, it was accessed. So I won't read through each of the testimonials, but these really speak. These are first-hand testimonials from survivors. We conducted focus group and in-depth interviews with individuals who had used Chomi to understand their use and experience. And what these speak to is empowerment, is options, is being able to be connected right away when I didn't previously know how. And also important, I want to specifically point out the orange block because many of us do GBV screening and inquiry in our work. However, this is extremely difficult questions that we are asking. Our staff go through these motions of asking the questions because it's in our work. However, you're asking someone to disclose very personal aspects about their life they may not be ready to do. So it's really important as we think of programming, how do we give people tools that even if they're not ready at that moment of service, they can connect back in when they are ready. So in conclusion, accessible user-friendly technology has a role to play in improving gender-based violence services. Safe, anonymous access to GBV information via a chatbot can both reduce barriers as well as drive GBV awareness. And lastly, multilingual GBV information is needed. And I really want to stress this part. As we were doing the translations for this, one of the social workers said to me, "I don't know that word in Setswana." And I said, that's exactly why we have to translate it. Gender-based violence affects our society, our homes, our families. If we cannot talk about it, we cannot change it. So I'd like to thank Grand Challenges Canada for funding the creation of Chomi, the Chomi co-creators, as well as our social work and IT teams who bring this work to life every day, but most importantly, the survivors who put their trust in us. Thank you.
Good afternoon. My name is Mandisa Zwane-Machakata. I'm from Surface, Eswatini, which appears as Swaziland in your program. It's the same country, don't worry. I'll be presenting on the digital use of social accountability monitoring for sexual reproductive health rights, which we call SEM for SRHR, as a key strategy to improve uptake of youth-friendly services in Eswatini. So I think we've established already the background around, how we are progressing relatively well in our region towards getting people tested, getting them on treatment and viral suppression. And yet we still have groups that are lagging behind, which include young people. So it's against that background that the application I'm going to speak to was also developed. Eswatini developed youth-friendly guidelines, and all health facilities were trained, and we had focal persons in the facilities to make sure that the rollout of the guidelines continued. And yet we found that even where a facility was trained, where the healthcare workers were friendly, young people were still going further to other facilities to access services. They still didn't have the confidence to use their local health facility, which affected adherence, it affected uptake of services, and it affected how they were able to access services in their community. The Mobi Surface application is a web-based and also application-based application, which can be found on Android. Sorry, iPhone users. Yes, it can be found on Android, and can actually be shared through ShareIt, but it's also web-based, so you can actually access it on your laptop or computer. And what we've done with it is, when the application was developed, we capacitated the facilities with tablets that are placed in each facility, in the youth-friendly corner with the application. The application basically empowers young people to be able to give feedback on how they're accessing services, and to actually say whether the services are youth-friendly and whether the services are meeting their needs. If they are not, they're able to log what we call an issue or a ticket on the application, and it is actually received in real time by the head of the facility. The way that it's structured is such that if a young person goes into a facility and accesses a service, I'll use myself as an example. I can log into the application, register. I do not have to say I'm Mandisa. I can say I'm Thick Mandy, Marvelous Mandy, or whatever I want to call myself if I want to be anonymous. And then if, for example, I've had an issue with accessing my choice of family planning commodity and it wasn't in the facility, I can then log that into the application to say I came in for family planning of a particular, for example, I wanted the implant but I didn't get it. And then at the moment that I put in and I click send, it goes to the head of the facility to let them know that a young person has come in with this issue. And then immediately the head of the facility gets a notification, to which she then responds by sending to one of the service providers within her facility, whether it's a focal person or whoever it is, and then that person must attend to that issue. Once the issue has been resolved, the application is then, a message is then sent to me to say your issue has been resolved. I can then go back to the facility to say, yes, my issue has been resolved, and close my issue or my ticket. Or I can say it has been resolved, but not to my satisfaction. I have a further issue on it, and then log that as well. This slide actually speaks to that initially when we started it, it was an implementation science research pilot where we worked in a few facilities. We tried to target facilities that were outside of the DREAMS and Global Fund coverage so that we were reaching young people who were not already filled with access to services through mobile services and other approaches. The approach also includes strengthening the community component of service provision by working with youth networks in that particular region or area, as well as working with service providers. And then from there, once the pilot has been put into place, we then look at the data that comes in periodically. The facility is encouraged that each time that the issues come in weekly, they must, through their weekly meetings, review all the issues that came into their facility that week. And once they do that, they're able to read them, they're able to resolve them as a facility. That way, the whole facility is aware of the issues that are coming in from the young people that are their clients in that particular area. The methodology, as I mentioned, was looking at targeting health facilities that were outside of the DREAMS and Global Fund coverage areas. Tablets were placed in the health facilities. Young people were also given access to the application because you can download it from the Play Store if you have a smartphone. They were also trained to become champions in order to recruit other young people to take up use of the application. And then we trained also the healthcare workers on the use of the application. While initially what we wanted to do was give client feedback, we also found that another result of this application is that we saw that it increased the use of the local facility by young people. In some facilities, usage actually went up by 4 times, which meant that when young people got the power to be able to give feedback, they gained more confidence in their facilities and they actually went back to using those facilities. I'm not going to go into the data because I can see my time is already being mean to me. But in conclusion, we found that utilization of social accountability monitoring actually empowers young people not just to give feedback on how they're accessing services, but it also gives them confidence that when their issues are reported, they will be addressed. And it strengthens the linkage between the community and the facility, because once the young people have confidence in the facility, they return back to the facility that is closest to them, which can actually have better outcomes for us in terms of adherence and ensuring that utilization of services in the coverage area where they are is actually met. I know it was quite a mouthful. I'm just in time. I'd like to acknowledge UNICEF, who is funding us to upscale the approach to the 15 facilities we are working in now. The government of Eswatini, the Ministry of Health in particular, because they are the ones who adopted the application and ensured that it is now being upscaled. We also would like to acknowledge Sweden, as they were the initial funders of the pilot and developing the application, as well as SAFAIDS, the organization that is working in this area. Thank you.
That's me. Hi everyone, I'm Brian Zanoni. I'm presenting this on behalf of Scarlett Burgum, part of our research team who is unable to make it today. I want to tell you about our mHealth intervention InTSHA, which is means youth in isiZulu, and it stands for Interactive Transition Support for Adolescents with HIV. So just some background. So retention and care for adolescents with HIV during that transition phase from pediatric-based care to adult-based care is often worse than younger children and also older adults. So in this study, I'm going to tell you about a pilot study, which was a type 3 hybrid randomized clinical trial of a mobile phone-based intervention, InTSHA, and the results of the pilot. So the intervention itself was based on the SMART model, or the socio-ecological model for adolescent readiness to transition. In this model, which is somewhat complex, but you need to know that there's sort of objective factors and modifiable factors. And so we took some of the modifiable factors that you can see in that square box there and saw that some of these things we can fix and we can address. And a lot of those can be addressed with an mHealth type intervention. So we used that as our basis to develop the intervention. So it was developed using participant-centered design. We used encrypted group chats that are delivered via WhatsApp to provide peer support and to improve communications between adolescents and their caregivers and their providers and among adolescents themselves during this critical time period of transitioning from pediatric care to adult-based care. The modules came up with 10 different modules. You can see them listed there. These were all suggested by the adolescents themselves in the participant-centered design. They were topics that they wanted to learn more about, wanted to discuss more with their peers about, discuss more with their healthcare providers about, and discuss more with their caregivers about. And so this was theater tested then based on those topics that we created. So we did it live in front of adolescents and in front of their caregivers and got feedback on the intervention themselves, anything from the wording that was used, how it was presented, and the information. And then they came back to us, and with each iteration we fixed it and updated it based on feedback from adolescents, from caregivers, and from healthcare providers. So in the pilot study, we enrolled 80 adolescents. 40 were randomized to receive the intervention, and 40 were randomized to standard of care. We looked at the primary outcomes of acceptability and feasibility, and we also looked at secondary outcomes of viral suppression and retention in care 6 months after they entered the intervention. So the primary outcomes, both acceptability and feasibility, were quite high. We set goals of around 80% as being goals that we wanted, and acceptability was 82%. Feasibility dropped a little bit off at 78%. Some of the issues with feasibility were the timing of the chats that occurred. Sometimes we couldn't get all the adolescents together at the same time. There was issues with load shedding in South Africa. There were power outages and poor internet access. So even though they wanted to at times to join the session, they were unable to. There were also issues with shared phones where an adolescent didn't own their own phone, but maybe were borrowing a sibling's or a parent's, and they couldn't have access to it during the scheduled times. And then there were lost and stolen phones and phone numbers changing, so sometimes between phone numbers they weren't able to access the group chats. And then particularly in our older adolescents, those in their final year of high school or matric year in South Africa, they had a lot of studying and overlapping school activities, so they often didn't have time to attend the scheduled sessions at the time. But they often did, even though if they weren't live during the sessions, they were all on the phones, and they were still able to read through the text and the conversations that all the other participants were involved in. So our secondary outcomes is we looked at retention and care. So compared to control, adolescents in the intervention arm had a 10% increase in retention and care at 6 months. For each session that they attended during the live sessions and participated in, there was a 60% increase in retention and care for each session that was attended. And if you attended 3 of these sessions, remember there were 10, if you attended 3 of the 10, retention and care was 100%. In terms of viral suppression, there was no difference in viral suppression, and about equal in both groups, in the intervention arm and control group, but both hovering around 90%, which is still pretty good. So in conclusion, InTSHA is a highly acceptable mHealth intervention that improves retention and care for adolescents with HIV and transitioning to adult care in South Africa. So I just want to thank my collaborators, co-investigators, and funders and mentors, all listed on this page, for their help in designing the study, in conducting the study, and writing up the study, and also all of the adolescents, their caregivers, and the healthcare providers that were involved in this study for their time and their patience as we were learning how to do this and how to deliver it all at the same time. So, that's it. Thanks.
Hello everyone, I'm Hildah Essendi from Triggerize, and I'll just very briefly be sharing with you some of the work we do within Triggerize or TICO Africa. We are rebranding into TICO Africa around reaching adolescents and young people with sexual and reproductive health. So we've heard a lot from the morning session and just from the speakers here, just really painting the picture of the magnitude of the health outcomes amongst adolescents and young people. And so I'm providing a case study for Kenya, although as Triggerize we work in a number of other countries within the region. But just to highlight some of the maybe two critical ones is that in Kenya, we see teen pregnancies really being on the rise, but a big percentage of these are really unintended pregnancies. It means there's a lack of protective measures against these unintended pregnancies. We also see that amongst HIV infections, new HIV infections, a big percentage of them as well, more than 50% are occurring amongst young people aged 15 to 24 years. And when we look at generally health outcomes amongst young people, adolescents and young adults or young people, we don't see the same trend across. So those from poorer backgrounds are more disproportionately affected. And we find that when we look at the literature and really the challenges that young people face in access of health services, we see a lot of issues or barriers. So number one is the unaffordability of SRH products and services. So a lot of young people really do prefer, for example, in Kenya, to access health services or the sexual reproductive health services from private facilities. But a lot of the time, there's a cost element which they cannot afford. When they do access health services, a lot of the time we see the services being quite unfriendly or the quality of the counseling being quite poor. And most importantly, there's stigma and discrimination a lot of the time, particularly when it comes to access of family planning or contraception, perhaps because of pregnancy status of these adolescents and young people, but also when they identify as persons belonging to the LGBTQ community. So we see a lot of discrimination across all of these factors. And so even when they do access these services, we see a challenge because most of the time they will not adhere to the service, to their FP method, to their HIV treatment, to their PrEP medication. So therefore, because of this lack of agency, what does TICO Africa do? So, or rather, Triggerize our work. So just to say, we work across 5 countries in Sub-Saharan Africa region. So it's Kenya, Ethiopia, Uganda, South Africa, and Burkina Faso. And so we use a digital platform. This TICO platform is a digital platform that connects young people to services. So it's a connector such that health providers become members of TICO, and when young people sign up to TICO, they're able to see the health providers engaging on TICO and the various services that they're offering, and so they can select the service they're interested in based on their need. And so this makes it easy. But aside from connecting young people so that it's easy for them to access health providers, we also use other approaches to encourage them to really access services. So we use a combination of things. and we provide information or information related to the SRH products and services that they can find through TICO. We use behavioral nudges to encourage them to access services. And we use an electronic voucher to help them really access services, make informed decisions about their lives. Now, these vouchers, critically, is that they help young people to access services without paying for it. So that cost element as a barrier gets reduced. Now, young people can sign up to TICO in one of three ways. Number one, they can sign up, if they have a feature phone, they can send an SMS to TICO, and TICO can respond back, and there's a bit of back and forth process, and then they are members of TICO. And from there on, they can access a service. They can also access or enroll onto TICO with a smartphone, through WhatsApp, through Facebook, through Telegram. But the critical thing is that TICO doesn't lock out any adolescent or young person who would like to access services just because they don't have access to a mobile phone. So TICO allows young people to access services even without a mobile phone. So we use digital smart cards that young people can sign up. We work with community mobilizers on the ground that sign young people up to TICO, and from there on they can access a service. And then when they want to come back for a refill, they just present the TICO number and they can get a service. So the critical thing about TICO as well, other than connecting young people to services, it also allows us to collect real-time data to understand who are we reaching, what service are they accessing, and so we are able to really do a lot of adaptive programming because of the real-time data that we collect on TICO. So very quickly, some of the nudges we use and reward mechanism. The services are 100% subsidized. So young people can access an HIV test, they can access an ART medication, they can access their PrEP service, and they can access their family planning method without paying. And for those who sign up with a phone or a smart card or a smartphone, we are able to send them reminders when they are due for their refill of their ART medication or their injectable. So we remind them that you're almost due to go for a service. Can you plan and go to the facility? When they access services on TICO as well, especially for those who have a phone, we allow them to rate the quality of those services. And when they rate, we reward them. We give them a small reward, which is equivalent to 50 cents of a dollar or less. And so this really just encourages them, number one, to provide feedback around the quality of services that are on there to help other young people, but also encourages them to come back later for a refill. And so, what impact have we been able to generate? So in Kenya, just in Kenya alone, within 2 years, we've been able to reach more than 400,000 young people. And these 400,000 young people have been able to access 784,000 services related to HIV, family planning, through TICO platform itself. We have quality assured providers on the platform, and because of some of the feedback that young people give, as well as other capacity strengthening approaches that we use, we are able really to strengthen the quality of services that providers engaging through TICO are providing to young people. And you can see 68% of young people signing on to TICO do not have a phone. So that actually means that what we do really kind of takes care of all of the young people in their diversity, whatever they are, whether they have a phone or not, and where they're hailed from, and the service they need. So in terms of the key takeaway for us is that just to give you just a snapshot of one of the dashboards that we built from our real-time data, we use a combination of things. So the nudges that we use and the real-time data that TICO allows us to get enables us to do adaptive programming. And we are also able to nudge young people to access a service and to stay onto the service for healthier lives. Thank you.
So thank you so much to our distinguished speakers. I think we learned many things today. First of all, that there's many challenges also in accessing digital services, but that they at the same time offer opportunities. And we discussed today also on how we can make it work. And it's so important to link it up to a real in-person services to make sure that these services are for free. And above all, maybe to involve young people in the way that we structure interventions. So now I would like to open up the floor for questions for our speakers. And we have another 10 minutes maybe, and then we need to round off this session. So who has any questions? I see somebody in the front and afterwards in the back.
Am I audible? For the great presentation.
Yeah, we can take two more questions and then we answer them. I saw one question at the back of the room as well.
My name is Chiso. You get me?
Yeah.
Okay, so my question is, what you looking at Africa, especially have those that are not want maybe you intervene places that of promote. Remember that even them, they do not really, they are actually concerned, and they are also, they also face issues that with sexual and reproductive health. So then, how accessible were the services to you guys? Like, how were they accessing the same services in line with everything that you're doing? I hope my question is clear. Thank you.
Yes. Okay, let's, these are 3 questions, so let's try to answer them, and then there's 2 more later on.
So address the first question that I don't think a lot of people could hear, but the question in the front was asking about on Chomi, if it's anonymous, how do you do follow-up for services? And to answer that question, it's anonymous until the point you request or connect to support services. And then at that point, we do ask for your name and in your cell phone number, which we already have in the app, so that's the only way we have you. If an individual can choose to not put their name in, and our social workers then will contact and say, we saw you reached out to Chomi, we didn't have a name, we just have a phone number, but we're following up for care. So it's up to an individual. They have a choice to put in their name, they have a choice to put in any information they would like to tell us, but those are both optional. And then I think we heard the gentleman's question around basically in kind of summary a lack of data and connectivity. And from our side, I think all the panelists would agree, and as well as Julian spoke in her presentation, there is no silver bullet. We are not up here saying that any of these solutions are silver bullets. They need to be embedded in broader programmatic services that are differentiated so people have options and choice. But this, many of these do offer options and can be overcome, data-free, 0 rating. These are all options that then can address low connectivity and data. But of course, you can never completely move away from in-person services. So how can then we drive through these services and these virtual platforms? How can we also drive to in-person? Thank you.
I saw some other speakers nodding. Yeah.
Yes. Hello? Am I audible? All right. I would like to speak to the issue on internet connectivity and how it remains relatively high for most young people. And with that acknowledgement, part of the work that we do is advocacy to see how we can make access to the internet more equitable, especially for young people in rural communities. Currently, the mobile surface application is being provided in health facilities, and health facilities do have access to the internet because we are using, as a country, the CMIS, which requires for there to be internet connectivity. We are considering maybe the next step would be also availability in schools, based on the fact that schools will have, but we cannot say that this is not against the challenge of the internet costs. Internet costs remain high in our region. I know in our country, it is a problem. So it does come with a lot of advocacy, and we do have an advocacy plan in place, and we are advocating to say we need to have equitable access to internet. As much as we are calling for equitable access to all services, that should actually include the internet, because the truth is the internet is that's where opportunities are for young people. Without access to it, it really is an injustice. Thank you.
Just to add on to that, for us at TICO, you could see a proportion of the young people that we reach do not necessarily need to have access to a mobile phone or even the internet. And yes, we see a proliferation or an expansion of access to internet and mobile technology within Africa. But within TICO, we work in poor communities, so in urban and peri-urban areas. But we recognize that we still have a big proportion of young people that do not have access to these facilities. As and when they expand, of course, we hope that more young people can sign up to TICO with a phone, because the phone helps us to send reminders to more young people, but also to collect a lot of, within TICO app, feedback research to help us improve the system and how we reach young people. So number one is really the TICO card, smart card. So we make sure that, within the ecosystem, when we set up the ecosystem, of course we have community mobilizers in there. We also have health providers in there. Community mobilizers must have a smartphone, must have access to internet, and as well as health providers. So that already, it helps us to get that extra step, to be able to reach young people, regardless of whether they have a phone or internet or not. So it's critical that the other players within the ecosystem have access to internet, and they're able to engage within this process, helping young people to sign up and helping them to access services. So so there's that recognition, but it's also a step in the right direction in terms of, if we get more young people to have access to internet and have access to phones, it will make our work easier. However, based on the ecosystem we work in, we are able to work with what we have at the moment. Thank you.
We're almost coming to an end. I had two more questions that I promised that could be asked. I see Aline.
Thank you, everyone, for the super interesting presentations. The aspect that caught my attention in a few presentations was the role of the caregivers and engaging them in assuring, what in their role to assure that there is adherence, right? Also to fight the stigma about their the kids or the people they're caring for to adhere to the services. Can you talk about the content that was given to them, and how did you approach them to ensure that they engaged in the project?
And the last question, back in the room.
Thank you so much. My name is Pagamani Moyo, working with PATA from Zimbabwe. My question is directed to TICO. It's a good initiative that you have, but I'm just worried about the economic aspect when it comes to these young people, because the services might be subsidized, they might be accessing these services for free, but it doesn't take away, or it doesn't really address the root cause of the problems that they are having as young people. Have you thought about strengthening their economic background, or maybe giving them income generating projects that will enable them to be able to be paying for these services on their own? Because I believe at some point this project is going to end. What is it that they are going to be left with? Thank you so much.
Who of the panelists wants to answer the first question? Brian?
So I can handle the first question, which, as a reminder, was how do we involve the caregivers? So in our InTSHA intervention, I didn't go into detail, but we did include the caregivers for the intervention. And so we had a total of 10 modules, and with each module, whatever topic we discussed, there was a similar parallel session with the caregivers. And so they were much briefer and much more superficial, but we introduced that, this week we're going to be talking about sexual reproductive health or tobacco and alcohol use, and how do you approach those with your adolescent. And so that was the approach that we used for the caregivers, was not really to teach them stuff, but to really how to interact with their adolescent to discuss these important topics.
And the last question with Tico, and then we need to run off.
Thank you for that question. So, Tico, we've been operating for, I think, about 9 years now. When we started our operations in Kenya, we were mainly focused on family planning, so supporting adolescent girls to access family planning products. And we recognize the importance of adding other offers to our ecosystem to support more young people, just to improve their health. So we've since added HIV testing to the ecosystem and the offers that we provide. And we added access to antiretroviral therapy and PrEP. So we've increasingly been looking at what gaps are there in terms of the services we are providing and how can we support young people to access more services. So really looking at integrated service portfolio. And so we've been as well adding, within the last 2 years, we've added another offer on the platform, which is on mental health screening and counseling. So we've been trying that out in Kenya. We are starting this work in South Africa as well as Uganda. So when young people enroll onto TICO, they can choose to access a family planning service, HIV testing, ART, PrEP, mental health as well. Now in Kenya, we've also been working with the Ministry of Health, Ministry of Sports and Youth, to really give more skills to young people, empower them even more. So within the last 2 years, we've been trying out a project in Kenya on supporting young people with job skills and employability. So we take young people through, we give them skills, working together with the Ministry of Health, and Youth and Sports and Affairs, to really empower young people, give them more skills around entrepreneurship. Provide them job skills, provide them skills around how to even interview, to get into an interview situation, write their CV, really empowering them to engage within the job market or to create business opportunities for themselves. So we've increasingly been recognizing that health alone, when we provide health services alone, is not enough, because there's that economic empowerment aspect that is still the big driver as to the health outcomes as we see them. So we are also trying out how do we empower young people with skills so that they are self-reliant and they're able to become more independent economically, thereby addressing their health issues. So this is something if it succeeds, we like to try out with one country, we are likely to expand to other countries as well. So we recognize the importance of integrated services and looking at what are the key drivers to some of these outcomes as we see them and trying to address those root causes. Thank you.
And thank you so much for this answer. I have a couple of more announcements to make. First of all, I want to ask everybody to complete the online survey. It will be sent to you by email. Then we will have lunch right now and also the poster viewing session with even numbers. And for the lunch, we can follow the staff. Well, I had to advise you to follow the volunteers. And the poster viewing will take place in the room right next to here. And the next session will start at 3 p.m. And I would like to ask you for a big round of applause for our fabulous speakers. Thank you so much.